Good evening, and welcome to a GP Town Hall, the future of primary care. It gives me great pleasure now to talk about what we're doing tonight. So, we're diving into the future of general practice with someone who just doesn't work in the system, she actively shapes it. It gives me great pleasure now to welcome Dr. Anita Muñoz, who is a GP, a clinic director, and a fierce advocate who has spent years lobbying at both state and federal levels for fair funding and doctor well-being. Anita's career highlights include serving as chair of RACGP Victoria and director on the national RACGP board, as a practicing Melbourne GP and clinic owner and medical educator with 25 years of clinical experience. Her leadership style emphasizes evidence-based advocacy, government diplomacy, and protecting GP-led care. Some of her past achievements to date include payroll tax exemptions in Victoria, the GP at Parliament initiative, a strategic program to bridge the gap between frontline doctors and policymakers, bringing working GPs directly into the political corridors to advocate for funding. Serving as the chair of the Victorian Faculty Council since 2020, she has managed regional member support, professional development initiatives, and local healthcare integration. And she has successfully campaigned to secure better funding structures for GP registrar training and has been a vocal advocate for trainee well-being. So no one better than Anita to talk to us tonight about the future of general practice. Welcome, Anita.
Hello, thank you, Nita.
This town hall is really about finding out what GPs want covered. They did a survey which kind of built upon all the concerns and questions, practical priorities that GPs have raised before the event. So we hope tonight we can address most of these concerns, and Anita can help navigate you through some of these and give some of a future direction, how she's going to help general practice come to a better place than we have been. I mean, I think all of us, as a working GP and a practice owner, also feel that there's been an increasing feeling of demoralization. And I think all of us are really looking forward to a brighter GP future. So, Anita, we're going to be throwing at you a lot of questions in that direction and sort of bring out all our challenges and frustrations, so that, we can try and have some optimism moving forward after speaking with you. So let's look into the survey and see what are the top questions that came up. So there's different themes. So the themes, we'll start with the first one, which is really funding, value and viability. I want to also say at the outset that I am actually speaking, a lot of these themes will come up in my own personal experience. And Anita, I'm going to actually talk to you as one of the lived experiences I've had along these issues. So I think I can kind of feel the pain that GPs feel in some of these. Now, Anita, what would you like all the listeners to go away with it as your top, messages and your top, I guess, priorities that you will kind of work on, about what you want to do, how you intend to do it, and give us some optimism about the future of general practice?
I like the question about optimism because despite the fact that I acknowledge that there are a lot of issues that we need to take care of in the coming years and beyond, I was a contractor GP for all of my career and I bought into my practice 4 years ago. Now, I would not do that if I didn't believe in the future of our profession. And I do believe in the future of our profession. And I would also say to people, I'm not a person prone to panicking. I'm a person prone to staying calm and strategizing and problem solving. And every generation of general practice and general practitioners has faced some kind of very significant existential threat. So in the early 2000s, it was the insurance scandal where it looked like insurance was just totally unaffordable. And the government had to be threatened to the point where GPs and obstetricians and plastic surgeons said, we're just downing tools and stopping work and we'll find another job. And that's when the reform over the extent to which the public and lawyers could litigate was brought in. And then there was reform over how much insurance costed, right? So that was a point where people were saying, I'm getting another job. I can't afford my insurance and I could be sued out of house and home. So the reason I'm saying that is that challenges come all the time. And one of my mentors, who I'm very fortunate to have, Mukesh Haikwal, has said to me, every generation there is a threat. We're always going to have a fight. Don't panic. just get smart, strategize, and think, how do you get around it? And part of the way you get around it is you don't just go saying, we have a problem. You go saying, I'm putting a solution on the table and I want you to compromise on this solution. And that's what I'm prepared to do. Just going and being shouty or just talking about concepts
No, doesn't
or
help.
getting into the room and then realizing actually, oh, I'm a bit intimidated and I need to be polite. And so I'm just going to, and then you
Yeah.
find out you agreed in the end. None of that works.
Yeah.
But I think we go in and we say, we do have a significant problem and we have solutions for you if you will trust us as your collaborators. So that is what I think we would do. And I think that we can be successful. But my parting comment is, although GPs in the main do not like politics, which I understand because I don't like politics either, now is the time to pay attention and to participate, to vote, and to be prepared to stand with your profession, because there is safety in numbers, there is power in numbers.
Yes.
And I don't want us to be 2 or 4 years or 6 years down the track going, geez, that was an opportunity that we squandered. We have to take up this opportunity and use it, and we have to stick together. So
And you're right.
please vote, and please bother yourself just a little bit with politics, even though it's actually quite irksome stuff.
You're right. You need a village behind you when we should be there. We just don't need to survive. We need to thrive. And
Yes.
be recognized. So thank you so much, Anita, for all your answers. I know there was a few challenges there. You did a brilliant job. And I think you do inspire confidence in that we can see light at the end of the tunnel. We think there will be positive changes. And I think we shouldn't expect only you to do the heavy lifting. We should all be behind you and working towards that, because it benefits all of us, So thank you very much for your time. So talking about funding and viability, I think increasingly GPs are feeling that it's becoming very difficult to really balance keeping the practice open and delivering good quality care. So how can Medicare better recognize consultation time, complexity that we function in, what the kind of care we provide? I think GP specialty is the most difficult specialty, but somehow GPs have been kind of relegated into a position of being like the community intern or the dog's body. And we just don't get recognition for the most difficult aspect of medicine that we practice. Now, how do you think this is going to change? Or will it?
Fundamentally, it must, or we're going to find that general practice as we know it will be under significant existential threat. And one of the issues that I'm acutely aware of is that progressively over the last 20 years, we have lost funding, which is an inverse relationship with the amount of complexity that we're doing in practice. So we know from a report that's just been released, co-authored by Michael Wright, that we had 8% of the federal health budget in 2003, and we're now down to a paltry 5.5%. So we're going in precisely the wrong direction that we need to be going. And at the same time, as every GP on this call will know, we're doing increasing complexity and we're dealing with much more multi-morbidity. We're also really, we have become the general physicians of old. So increasingly GPs are saying that there is no point in referring to public outpatients and other non-GP specialists because the waits are so long. So GPs are doing the heavy lifting in the community of what the general physicians of the early 2000s would have done. And so I find that this is a totally unacceptable reality, that as we're doing more and more, the funding is reducing.
Yes.
We also know that progressively we've been losing item numbers. And those item numbers used to reflect fairly that in a single encounter, we would deliver multiple types of value across multiple body systems. And progressively, we've lost those item numbers. I think it's absolutely egregious that last year we lost the mental health consulting item numbers, even though we know that our profession delivers 80% of the mental health that's rendered in our country. And so that tells me several things. First of all, it tells me that there's an ongoing lack of understanding of what an expert generalist is, and
Yes.
the way that we wrest back respect and recognition, which is one of the single most urgent things that our profession needs, is that we need to demonstrate what it is that we do, because where people don't understand things, they will fill that void with assumptions, and unfortunately the assumptions about our profession continue to be negative in nature. And so we need to demonstrate what that time and value looks like in general practice. Now, I think polite conversation and conversation behind closed doors can only achieve so much. Well, I think it's been extremely valuable to have those conversations, but I think now, in the next 2 years, we need to be shifting how assertive we are about these conversations and be willing to make those conversations more public. I am very aware that in the next 2 years, we have a federal election that will be in 2028, and we absolutely cannot squander that
Yeah.
opportunity to apply pressure to the federal government to get them to see what we are capable of and what our value is. And so that comes from long consultations and the complex work that we do. And I want recognition and respect for my profession. I don't want that to be mere conversational and narrative respect. I want that respect to be translated into funding that represents our value. So absolutely, we will be. I will be suing for increased remuneration for long consultations. I think that the length of consultation needs to be looked at. I think dividing it up into 6, 20, 40 does not represent the reality. So the whole thing needs to be reviewed, not just asking for 40% increase for level C, but actually can we redefine what those levels are and make them reflect what modern general practice is. We're not in the 80s anymore. We're not dealing with infectious disease and injury all the time anymore.
And you're right about, that we are seeing increasingly more complex patients because patients are living longer, they're more multimorbid. There's a lot of things we have to manage. And on top of that, as you said, getting into specialist clinics, whether it's public or private, is a nightmare. So they're waiting. So the care is left to us. Even after they've been to the specialties, they get dumped back in our court. We are left holding the baby. I mean, how often do I send an acute urgent patient to ED and then they do the bare minimum, send it back saying GP to organize outpatient cardiac workup, GP to do this. Nothing was done for that patient or even put into the system. So we are increasingly doing all the heavy lifting. Every specialist copies us into every letter and every result so that we are then legally liable if we don't follow up, which just adds to our workload. And there's zero recognition or payment for that kind of work. Now, I've been very interested in your thoughts on how do you, and if you were to be the RACGP president, how do you intend to approach this tension between this universal bulk billing kind of rhetoric that's out there and sustainable, viable general practice?
I think that this is one of the fundamental, most important things that we have to decide as a community, what we will and we won't stand for. So I have absolute respect for the fact that many Australians find it very difficult to afford care, but the social contract between those Australians is with the federal government and with our universal insurance scheme. And it is the universal insurance scheme that is failing them because it has woefully reflected the value of care and the cost of delivering care. And so I don't believe it's reasonable for our profession to bear the brunt of that responsibility and that ire from the media and the government and patients themselves, when it's actually the government that is responsible for setting the rebates, and the rebates belong to the patient. But I do recognise that there are members who feel very strongly that we can't charge a gap for vulnerable people in society. So this is a conversation that actually requires quite a bit of nuance. And I've spent a lot of time thinking about the way that we can look after vulnerable populations in particular and practices that service vulnerable populations, priority populations. When I did my Masters of Public Health, I was very taken by the approach that Professor Fran Baum from Adelaide takes on this. And there is a recognition that for high priority vulnerable populations who live with significant socioeconomic disadvantage, we do need to create a funding system that represents that. Now, people in Victoria will know that I have spent a lot of time in the last 9 months advocating very strongly for the co-health. And that is not to say that I absolve co-health of all of its responsibility for some of its governance issues. But the reason why I have fought so hard for co-health is because that I believe very strongly in the Australian model of community health centres and ARCHOs, which are a space which are designed to deliver care for vulnerable populations, where the funding system in there is not so heavily dependent on fee-for-service and not so heavily dependent on the patient being present all the time for the GP to be delivering care. If you understand that a GP's role is as a coordinator of care, and that often they are dealing with people who live with chaos, it doesn't make sense that the patient has to sit there all the time while the GP is delivering care or doing case conferencing or looking after some of their social determinants of health. And so I do believe Australia needs to have a way of meeting the needs of vulnerable populations where they do not pay a gap, and set that up and give that a funding system that recognises the kind of medicine that they do there. Having said that, we also need to rationalise the way that we are funding general practice that exists out in the community. Now, the bulk billing is not a financially viable reality for a number of practices. We know that some practices that have taken on the universal bulk billing have already started to close, and we know that the government knew before they dangled that incentive before us that at least 30% of practices would be significantly worse off, and they knowingly prosecuted that policy anyway. And so that tells me that the government has an appetite for allowing general practices to close under the burden of this bulk billing mandate. And I think that that is totally unacceptable, and I reject that. I think that the community thrives because it has general practice which is run by GPs who care about their patients. They want to have an ongoing long-term relationship with their patients. So one of the things that I feel very strongly about is that we must not allow general practice to have its clinical autonomy removed, its business autonomy removed, and its billing autonomy removed. If we do allow ourselves to be walked down that path, and as people on this call will know, I am certain that we will end up working and living in a system that resembles very closely the NHS. Now, the NHS is a catastrophe. It is the best example of a disaster in health system policy in the OECD, and I don't think that it is forgivable that we have a government that will allow what has been demonstrated to be an abject failure to take hold in our domestic environment. So we need to be able to charge what we are worth. And then the universal insurance scheme needs to reflect the value and the cost of providing care.
And to your point earlier, where you said about, the rebates need to go up, commensurate with the kind of work we do. And if they did that, we know that general practice care is the most cost-effective model of care. Government saves millions of dollars if they would fund general practice properly, because we keep patients out of hospital. We manage all the complexity. So they would actually save money in the long term. And knowing that, I think if they remunerated GPs well, a lot of us, like I sometimes joke to patients even and say, I'm like Robin Hood. I rob Peter to pay Paul, because I know patients of mine who are well off, who can afford the gaps, get charged the gap, then I can subsidize my not so well off. The socially disadvantaged, the people who need to come in frequently with complex needs, I can't possibly charge them. So I don't deny them care, but then I can afford to do that if I can get enough to keep my practice open, pay my nurses, pay my rent, pay my staff, and yet look after this vulnerable segment that you alluded to. So that's right. You're right about if they could only get that funding right, it would serve, it would really help all our goals and benefit every patient in this country. It just needs to be, properly thought of. Whereas we are now seeing, even on television and those ads and this messaging, which is so counterproductive. And almost, when it first started, it almost made us sound like mercenaries, that every practice should be doing this. You should flash your green card. And so much so, I don't know your practice, but I know our practice had to put out a statement on the website and in our waiting room to say why we cannot do universal bulk billing, to explain to them that we want to deliver quality care, we want to keep you safe, so we are forced to charge. And patients really got that. They understood that. They didn't judge you for it. But you're right, there has to be some lobbying. And do you think the RACGP is a powerful enough advocate for GPs? I mean, do they really, or do they just spend all their time on clinical standards and CPD requirements? Because a lot of GPs I speak with say, for the fees that RACGP charges us, what do we get back in return?
I think this is a really important question, and the fact of the matter is that the RACGP is a huge organisation and it has multiple functions.
Hmm.
And actually, that is as it should be. I think if we say, look, we're going to have less of a focus on standards and training and accreditation and all of that, we really would cease to be a college. We need to remain an academic college, setting the standards. And I have enormous pride, and I do get a great sense of well-being and belonging from being a member of the college. So I think that element as an academic college is very important.
Of course. I
But
mean, getting fellowship is a gold standard achievement for all of us, and everyone respects that for sure.
correct, but we have been told loud and clear over the last 10 years in particular that the members do want and expect advocacy in return for the fees that they pay, and I am in total agreement with that. And I think that I have an appetite for increasing the efforts in terms of advocacy. I do have the stomach for that, and I have a healthy risk appetite when it comes to having conversation with government. And the reason for that is I know that government doesn't expect every stakeholder to go to Canberra and politely agree with them. That is not why we go there. We go there to advocate. We go there to provide diversity of views. We go there to represent the members who are paying us to go there. So I know that politicians are experienced enough to know that they don't expect me to go there and agree with everything. There is an expectation that we work together and we try and find solutions. But I'm there for my profession and for the future of my profession and to represent the interests of my members. And I take that responsibility very seriously. And I know that at the moment we have got an existential crisis facing our profession. And we've already lost many general practices in the last since about 2008, we've lost about 2,000 general practices already, and they are closing. And I want general practice to thrive, and I don't want GP owners to lose their businesses, and I don't want GPs to lose the right to choose whether they want to run a business or be a contractor GP or find a means of being a salaried GP. So we do have to up the ante. That is my opinion. I do believe we can make greater use of our relationships with the media. I think we can be proactive in the media. And I think we need to take the story of what actually is an expert generalist and what does it do for Australia and the health system and create those stories and put them out into the Australian zeitgeist. Because nothing will influence Canberra more than having patients stand with us and say, don't you allow this sector to be destroyed, because general practices functions is what the voters want. And so my response to your question, Anita, about is RACGP enough? I have an attitude that you need to take your cousins to a fist fight, right? So if you're going to prosecute an argument, you are much better off going with people who will stand as your allies than going alone.
Yeah,
not sure that we've done that as effectively as we need to. And not only do we need to take other peak bodies and colleges, but we need to take patient bodies.
I agree. Patient voice is a very powerful voice, and we really need to leverage that. So I'm going to go into a very touchy topic now, which we all are really very cross about, which is, how is, the challenge of pharmacy leaning into our GP roles and carving out more and more of our income and taking it away, like prescribing, all of that. How does the college intend to advocate for GPs on that issue?
So the college has already commissioned an independent report that looks at the international evidence of this, and it finds that there is no evidence that it is safe, and it hasn't been demonstrated to be safe, nor is it cost effective. And so we published that, and I think that is a very helpful start, because we do need to go with data and evidence, because the Guild accuses us routinely of just making things up. I did an interview today for a podcast with Mia Jesserin from the Grattan Institute on the report that they've done on the future of pharmacy. And that their report is scathing of the relationship between the Pharmacy Guild and the government. And
I'm so glad to hear that, because that's what we feel.
it is a fantastic report, and I have recorded that podcast this morning because I want that report to keep circulating in the media and in the medical media, because I don't want it to be buried under guild propaganda. The guild is already saying it's all about supermarkets taking over pharmacy, and of course that's an infantile reading of the report. But we can use that report. We can use the college's independent report. I've also encouraged members and GPs to be sending me instances of pharmacy harm, and I now have hundreds of examples of
Oh, yes.
pharmacy harm. And so I have an appetite for having this conversation in the public realm as well,
Right.
because once you have organisations that are so independent like Grattan, that gives us a lot of weight, and it legitimises our point of view. I also asked the college to become a member of CEDA, the Centre for Economic Development in Australia, which they agreed to do. We are now members, because it is very clear to me, from a strategic point of view, that any conversation we have with government now must have a very heavy economic and productivity lens. And we know that you do not get bang for your buck with pharmacy prescribing. It is not particularly productive or economically viable, and it's costing taxpayers billions, and it's not delivering what it purports to.
Absolutely. I'm so glad to hear that. So we might move to the next slide. And just on the note of pharmacies, it's so ironic that pharmacies get paid to do immunizations, but us practice nurses are not given like really an immunization payment as such for every vaccine they deliver. So they took away the nurse item, number, and restricted it to such, strict criteria. So I think it's just a very unfair process. So I think GPs are also, a lot of GPs, more than 57% have spoken about this, administrative and regulatory burden. And, how all these complex changing MBS rules, sometimes even things like our ECG, to do an ECG rebate was slashed because you weren't given money for reporting it. I mean, who does an ECG and doesn't look at it and analyze it? We're not clerks just doing an ECG. So the government decided that they will only pay us that much. Now, I guess finally they kind of come to their senses and reinstated reporting the ECG rebate. And this whole dance that they play with our MBS rebates for item numbers is really frustrating. And trying to keep up with all those rules, that can you bill this with that, or can you bill for that? All of that's becoming a nightmare. So that creates a lot of extra work and uncertainty. And a lot of GPs who are not up to date with some of these miss out. And on the other hand, of course, we know there's some not so, favorable sort of characters out there who are encouraging GPs to do the wrong thing because they just want to generate more income. All this paperwork, duplication, do you have any sort of thoughts on how this could be alleviated?
Yeah, look, the MBS is it's a mechanism for control as much as it is a mechanism for funding a health system. And there have been studies that have been done in Australia that suggest that GPs underbill our insurance scheme by about $2 billion a year. And we do that because of the complexity of the system and because we are frightened of compliance. And in actual fact, the egregious compliance behaviours that occurred during COVID are still ringing in the minds and the ears of GPs who suffered under that while they were trying to help the nation manage a colossal pandemic. So the rules are too complex, and the fact of the matter is that they've removed a lot of item numbers, and so we have fewer item numbers. Some of the item numbers we do have are so complex people struggle to use them or are frightened to use them. And so we do need to simplify the rules. I think we need item numbers that reflect the complexity of what we do. A hill I am willing to die on is getting back those mental health item numbers, I can assure you, because taking away those numbers and then creating pop-up shops for digital mental health in hospitals, I think is something that I'm still struggling to come to terms with. And that was the announcement from last year. But I think that we need the rules rules to be simplified. And one of the things I recognise is that characters like Margaret Foe have gotten into the ear of government and have inserted a narrative that the majority of GPs and doctors in Australia are behaving fraudulently. And in actual fact, the system is rorting us because we are underbilling because of an environment that is fear-based. And so I think we really need to work harder to debunk a lot of the myths that have entered the zeitgeist about the greedy doctor narrative, which I reject entirely. And I'm very willing to defend my profession and say that if you spend 10 years becoming a consultant GP and you spend hundreds of hours educating yourself every year, and then you take on the responsibility of making decisions that literally are life and death, then you have the right to be well remunerated. And so I reject this idea that general practice should be run on the smell of the altruism rag. I believe that and I do recognise that we need to help ourselves, because sometimes we allow ourselves to use altruism to run our industry, and we do need to draw a line in the sand on that at some point.
And they know that we GPs really have the social conscience that we do want to do the best for our patients, and we do it to our own detriment sometimes. And now that's a good segue, talking about this TV programs that are aired, which talk about GPs being, like dishonest and rorting the system, and those kind of statistics that they pull out are really shocking, because that really misleads the public. And hence, I feel that also encourages some of the members of the public to make very frivolous and vexatious complaints, and then the GP has to, on top of all the other administrative burden, all the other stress of their work, which is so complex, deal with all of this, complaints from APRA or processes. And sometimes, even though it all comes out in your favor at the end, that's a lot of stress, time, effort wasted.
Look, I've said, Anita, for as long as I can remember, certainly well before I became chair of Victoria, that I have deep reservations about APRA as an organisation. I believe that it would be in everyone's best interests if we could just start again with our regulatory bodies, but I recognise that is not a feasible proposition. But I am deeply concerned about the fact that I don't believe within APRA there is a genuine intent to reduce the impact of vexatious complaints. I hold APRA responsible for the death of at least 16 of our colleagues, and I think that is a reprehensible statistic. I also am very concerned that APRA is incrementally reducing the rights of medical professionals to hold political opinion. Now, there is it is an absolute self-evident truth that racism and any form of hate speech in Australia is abhorrent, and I reject that entirely. But I do believe that the medical profession has a professional, ethical, moral role in the health and the lives of people and defending their right to live safely and healthily. And we do have the right and responsibility to make comment without taking sides, of course, because the medical profession is and must remain politically neutral. But I think it is absolutely true to say that things like war represent a dreadful impact on health and safety, and that it can cost the lives of medical personnel who are caring for people in those zones. And I do think that the medical profession has got a social contract with the community to call out where health is being threatened and where people are living unsafely. And so I believe that we need to make sure that we preserve our right and responsibility as a profession to speak to issues of health. And I remain concerned that incrementally some of those rights may be eroded unless we are very careful about how we proceed.
let's let's talk about, I guess, workforce training and well-being, which is again a very big area of concern, I think, for a lot of us. Like you mentioned, like how many, doctors have left general practice, and how it's not such an attractive discipline for a lot of young, medical students. When they come to our practice and they come for their placement, and you say, "Hey, are you going to take this up as a career?" Well, I don't know. It seems very difficult. We watch how you guys have to do so much. You are responsible for sifting through such a heterogeneous representation, whether it's life threatening or not, which system, which body part, from cradle to grave. You guys have to swing your mindset every 15 minutes. They find it very challenging,
Mm.
and they can see that the time pressures are enormous. So how we're going to make sure that we make it an attractive area of medicine, and how do we recruit and then retain those people?
Mm. Look, this is a fantastic question, because there are multiple layers to this that are really important for us to grasp, and then for us to prosecute when it comes to policy and funding. In Victoria, we were the first state, and I am very proud of my advocacy in this, to achieve the $40,000 stipend, the Victorian stipend, in recognition of the fact that registrars take a significant income hit when they enter general practice in the first year.
Yes.
And we achieved that stipend, and then that was taken up nationally, and it's now a permanent national policy of the federal government. So I think recognising that loss of income was a significant issue, and we have had a much bigger influx of registrars entering training as a result of that. But it's not only about that. I think that we need to talk about rehabilitating
Mm.
the reputation of our profession. And a absolute priority for me is to wrest back respect and recognition for our profession, not only from government, but also from the media and from
Yeah.
patients themselves, and from non-GP specialists.
Yeah.
Now, in fact, quite a lot of non-GP specialists tell me that they would stand beside the college and make it clear to government that the whole health system would collapse without us. And I
Yeah.
intend to recruit those people to help
Perfect.
prosecute the argument about our value. But we really need that pressure to be coming from the media and patients as well. And so I want registrars to have pride and excitement about entering what I still believe is the single greatest specialty in medicine. There's nothing better than being an expert generalist. I can treat any condition, any age, and I have a whole heap of skills across different body systems. It's a very good feeling to be that well trained and to have that much knowledge and skill. Now I need the rest of the world to understand that that's what I'm capable of. And in particular, when I think about RGs with advanced skills, who are doing anesthetics and obstetrics and palliative care and emergency medicine, and unbelievably talented and gutsy people. And I think that their value in our health system is, if any of us were marooned on an island or in an apocalypse, the one clinician I would want to be marooned with or in an apocalypse with is an Australian GP, rural generalist with an advanced skill. They are so well trained. So I want that pride to return. I also want people to be proud to be members of the college. And so I think that there's a lot we can do to help people want to enter training. I think that there's some bureaucracies inside of the college that we can dispense with.
Yes.
I think we need to ask ourselves, we need to ask the government, what is all the dumb stuff that you're willing to get rid of?
Yes.
Unless it improves quality, safety, and transparency, dispense with it, because you're making everything too complicated. And every time government applies a new layer of regulation, it costs everyone more money. So you need to be very sure that you're going to produce value with that extra regulation, because often all that happens is the cost of everything just skyrockets.
Yes. And to your point about like being recognized for the special skills that these GPs have when they're working in these rural areas or regional areas, and they're not recognized. I mean, a good example, even metropolitan areas, is marina insertions. Like, what is the rebate? Paltry. It's disgusting compared to what a specialist earns. A gynecologist once said to me, "Why would you as a GP want to take the medical legal risk of inserting a marina for getting paid peanuts?"
Hmm.
So that's the thing. Now, there is a question from the audience. The AMA they do have their recommended fee schedule, which is significantly above the government,
Mm.
schedule fee. Does the RSGP have an intention of trying to give us similar, maybe, model?
Absolutely. I think that we need to say this is what our services are worth,
Yeah.
and the rebates fall woefully below that. They're less than 40% of what our services are worth. And now I've said, and I would continue to say, that I think GPs should charge what they are worth.
Yeah.
I do understand that many GPs just feel that they simply cannot charge some of,
Mm.
their populations. But
Mm.
I also would put the challenge out to all of us that I don't believe that any GP in Australia should be paying out of their own pocket, out of their own revenue, in order to conduct a procedure on one of
Yeah.
their patients.
Yeah.
So I draw the line at saying, if you're willing to bulk bill because you can make incentives work, and you can use item numbers to your advantage, that's great. But the most expensive part of our business is the treatment room. And I
Yes.
hear year in, year out, and when I tour around Victoria, that people are losing money on doing
Yeah.
procedures. And I think that that is absolutely unacceptable. I know that if we said to a patient, you need to travel somewhere else to get your skin cancer removed, it will cost that patient significant amount of money in petrol and in lost earnings and in taking days off, etc. So I
And
really struggle knowing that GPs are paying out of their own pocket in order to deliver procedures.
And the stupid rules, like you can't charge for dressings, very expensive dressings that we need to use on patients day in and out for chronic wounds, because it's called, you're doing illegal sort of billing there because you've built an item. You can't charge separately if you are delivering some extra, care to the patient. So a lot of practices then say, well, we'll have to then send the patient away to the pharmacy to buy those dressings. A lot of inconvenience, very expensive for patients to buy single dressings, but we just then suck it up and we just give them dressings without charging for it. So there's lots of these areas of leakages and real losses in the treatment room that you just alluded to. Talking about career proposition, you know, look, female GP force in Australia have become a central pillar, right, of healthcare. And women, even though we make up half of the GP training pipeline, they kind of really are penalized, I feel, in terms of the Medicare rules. So it's almost like a gender penalization pay gap, because women GPs tend to spend longer during consults, see the more complex patients, do a lot of women's health, do also a lot of chronic disease. Mental health is they attract a lot of mental health, right? But they don't get remunerated, commensurate with the time and effort they spend. And a lot of them work part time. So for them, working part time, seeing fewer patients just doesn't make it financially viable to have nannies or daycare for their children who they leave to come to work.
Mm.
And we are disincentivizing these, critical, workforce of general practice.
Yeah. Look, my butler made the comment that he's not aware that there's any gender pay gap or disadvantage for female GPs, or any data that demonstrates that. And I think that there was not a single GP and patient really in the land who believed that that was a genuine comment. I mean, all you need to do is go on the ATO website and you can see the data. It's
Yes.
presented in graphical representation. So we all know that this is a reality. And if we've got a government that says that actually cares about women's issues and it cares about women's health, then it needs to recognise that it must support female GPs to deliver the care that they do, which is complex care.
Yeah.
Now, the government signalled to me that it's contempt for the work that female GPs do by removing their mental health item numbers, and I
Mhm.
think that they did that because they felt that we should not be co-billing,
Yeah.
and so it is an absolutely essential that we take on that fight, because we are going to lose our female GPs, and so that is a hill I'm willing to die on. Is that we need fair remuneration for people who are doing the heavy lifting. The fact that the MBS returns you less and less remuneration per minute that you spend.
It's a diminishing return. Yeah.
Perverse incentives that we have been warning about and talking about for 2 decades. And in actual fact, rather than heeding our warning, they doubled down on it with the bulk billing incentives from last year's announcement. Now, we're all bearing the cost of that because we now actually have general practices in the country that have got signs up saying you will only be able to discuss one issue each consultation. We're not doing more than one issue. Now, that is so illogical. And all it means is that people still have the same care needs, but they have to come to the general practice on 3 different days to deal with 3 different issues. I think that it is so illogical, but it also means that we're delivering lower value care, and patients are taking time off to attend 3 separate appointments, etc. So we need to defend the value that people who are willing to take time and do complex medical care, and make it clear that by doing that care, you keep people out of hospitals. So I feel very strongly about this one, Anita. And just going back to billing, I am very committed to advocating for decoupling gap payments from bulk billing.
Yes,
that a
that would
patient
be a really important, move for all GPs.
Yeah, it's just another coercive control strategy that basically forces practices to bulk bill, and I think it needs to be dispensed with as a matter of urgency.
Let's talk about GP registrar training policies, and what the framework is. And are you seeing any possibility of changes that will positively impact on that sort of part of RACGP's role, because they've taken over now the role of GP training? How can we make sure that practices and supervisors are well remunerated for the effort and time? Like, I know I've got registrars, and boy, how much time and effort is spent, supervising them, teaching them, and helping them out. Besides the protected teaching time, there's always on the go, continuous, help that you have to give them. Every time I'm away from the practice, I feel so guilty. I give them my phone mobile to say, call me anytime, and we're talking on the phone constantly, because I just feel they are my responsibility. But that's all unpaid work for me. Or instead of seeing patients, I'm spending time with them. And
Yeah.
I don't think the payments reflect that.
No, of course they don't. And look, this is just a metaphor for the entire relationship that we have with our funding systems and general practice. There is an expectation that we will fill the gap with our love of the profession and our commitment to our patients and the future. So appropriate remuneration for supervisors, absolutely. We've been asking for it now for some years. And look, I do accept, and I invite people to understand that you never go to Canberra, ask for something once, and get delivered it in a single advocacy cycle. You do need to be at it year in, year out, and eventually a budget cycle will come across where there's an appetite for pulling the trigger on an idea, and then it happens. So I think one of the things I've got is the experience to know that advocacy is a long game, and that you can advocate for some years, and then the themes are in your favour, and then you can get the funding asked across the line. So I'm not prepared to give up on the issue of supervisor funding. I also recognise that we actually need to make it much easier for registrars themselves to access their flexible funds, and for there to be more transparency and ease of dealing with the red tape of training, and making sure that they're accessing all of the grants and the things that are available to them to make their training easier. But I'm not going to give up on supervisor payments, because I think what we need to recognise is a person who's willing to share their expertise and teach is a unicorn, and they should be treated with great respect, because without them, there is no future of medicine at all.
Yeah. So talking about being, respected, validated, and recognized, let's talk about IMGs. We know that IMGs form a major segment of, the health force, especially in rural and regional Australia and workforce, and they are really keeping that system alive. Otherwise, we would not have any healthcare in many areas of Australia. I'm going to now talk as an IMG myself. When I first arrived in Australia, without too much self-revelation, I could say that I quickly realized that the path to being registered as a GP in this country was not just academically rigorous, which it should be, but structurally very exclusionary, I'm sad to say. I come from a nation of people whose command of English is a well-recognized, thing globally. I mean, we have Nobel laureates in English literature. In my AMC exam, I was actually asked, "How come you speak such good English? Did you learn to speak it after you arrived in Australia?" Which then reflected a pretty distinct,
Mm.
bias to me straight away. And that kind of really made me much more, I guess, compelled to recognize that we need to do something. And RACGP needs to do something to ensure that the brilliant global talent that enters our country is not met with structural, sort of like obstacles and
Mm.
unnecessary barriers.
Mm. I feel very strongly about this one, Anita. And the minute I became chair of Victoria, I started receiving requests for assistance from IMGs to
Mhm.
resolve bottlenecks or being caught essentially in a loop
Yeah.
where the requirements of the various systems clash in such a way that people just end up going around in a circle, and they meet the requirements of one regulatory body only to slip through the cracks of another one, and then having to either start again or being told that they
Yeah.
need to exit,
Yeah.
or that their visas
That's my
are
first place.
in jeopardy, or they need to go back to the beginning of training, or in some instances go back to hospital and then
Mhm.
gather more experience and then come back. So
Mhm.
this bothers me deeply. The CRUC review certainly put a lot of this under the spotlight, and I remember giving my expert advice at the CRUC review, and I think that we've still got a long way to go there. It pains me to tell you, but the reality is we still do have a lot of racism in
Oh,
healthcare
okay.
in our country.
Yeah.
That is
No.
racism towards patients, racism towards doctors,
Yes. Yes.
and that is an absolute priority.
Yeah.
But we need to be, there's two elements of what we can do here, Anita. The first thing is that we have to advocate to the external agents to
Mm.
say we have to be more streamlined, and there needs to be a greater sense of logic. And the deadline of being on your path to fellowship within 4 years of commencing
Mm.
just does not recognise the fact that there are significant bottlenecks that each of the regulatory bodies adds to the burden of the
Mm.
journey and the trajectory of the IMG. So we need to have greater flexibility and recognise that 4 years actually can be a very unrealistic deadline to meet.
Yeah.
And then we also need to look inside the college and say, well, where are our own processes adding to that with red tape, or where are we clashing with what we know is happening with the other external peaks?
Mm.
And I've long wondered, and I would like to ask the question about the AMC exam, because
Yeah.
I do wonder if there is an exam where the pass rate is in the 20 to 30% range, is the
Yes.
exam the right exam? And we've
Correct.
been told for decades that the AMC exam represents the standard of Australian medical graduates leaving university. And I've always thought it would be very
No, it
interesting.
doesn't. Having done it myself, I can tell you, I have done MRCP exams. I've done so many international exams, American exams. This exam was a league of its own.
Correct.
Because it was an exam meant to fail you, not to actually test your. So no, absolutely not. And I think there was someone I read somewhere soon after I finished the exam that they tested Australian graduates on that exam and they performed miserably.
Yeah, that's right. And I say, well, let's just go head to head.
Yeah.
Let's have a cohort of IMDs and a cohort of just graduated Australian medical students, and actually test that theory, because I am deeply concerned that we are setting people up to fail. And of course, once you enter the country, if you
Mm.
think about what somebody does, they've they've left their country,
Yes.
enormous expense.
Displacement for their
They've come
family.
in, they can't earn because they can't practice their craft, and the fees to enter, and then the fees to
Mm.
register, and the fees to sit exams. Now,
Mm.
I defend Australia's right and responsibility to uphold a very high medical standard,
Yes, we
but
do need to maintain that standard.
I've been a medical educator for 15 years, and I've been involved in writing exams and standard setting exams. And my question is the exam the right exam if the pass rate is 20 odd percent? And so I'm very
Yes.
interested to ask those questions.
Yeah, no, be fair. going to talk about sort of, I guess, access, equity, and continuity, which is kind of, we've kind of covered a few things, but you've talked about, how we can offer help to the disadvantaged or the complex patients and not, still offer them bulk billing if we have enough money in our kitty to do that. Now, the cost and timeless, the fees, the long waits, and limited public or specialist services, the delay in care because the waiting times are blowing out. But even before we get there, I think personally, I don't know how you feel, that even the communication between tertiary and primary care is appalling. We never get timely discharge summaries. Even when a patient goes to ED, we go and look up. I don't know what you do in Victoria, but I know in Queensland, I look up the viewer on Queensland Health Portal to see what happened to my patient. Did they send them home or did they admit them? And what's going on if I'm worried about a patient. I don't get any stuff. But the patient comes, fronts up on my practice and says, "Oh, you got a letter about me. Now tell me what happened and what do I need to do?" And I go, "There is no letter." So there's a really like very poor sort of communication and a lot of dumping back to us, I think, at the end of the day. What do you think can be done in this area to help bridge this gap and improve patient care and make it more, expedient and timely?
Yeah, look, I've had the experience of being involved in the Victorian health system on system reforms over the last 6 years. One was a project at looking at timely clinical handovers. I don't like the term discharge summary because it just means get out of my hospital.
Yeah, that's true.
It's a clinical handover. Also, I was involved in the planned surgery reform in Victoria, and also now the specialist outpatients reform in Victoria. So these themes I'm very familiar with. And what I recognise is that good reform does need investment. Certainly in the state of Victoria, we have limited funds to implement a lot of the fantastic innovations and ideas I witnessed being put on the table. But I have, and I'm custodian of those ideas, and I know that there are things that you can do to improve this. But it really comes down to political will and to a communication with the hospitals that you need to be meeting a standard for clinical handover. And we need to signal that it is the heads of units and the consultants in these units that should have responsibility for making sure that that handover is done and that junior staff are trained and supported to do them. Because it is one of the most important documents and it is a bridge between one arena and the other. And without it, there is serious safety issues that can happen to those patients. The other thing that I find really difficult to accept is that a recent study that's been done in New Zealand suggests that GPs are spending 31% of their time in non-face-to-face administrative tasks. Now, that is worse than the NHS. The NHS GPs there are spending 25% of their time on non-patient facing tasks. Yeah, well, in Australia and New Zealand, we're now at 31%. So first of all, that's all unbillable time. So 1/3 of a GP's time, just like that, is totally unremunerated. But it just tells me that we're spending so much time compensating for the failures of the system. And again, I think that not only is it a waste of our time and disrespectful of our time, but it indicates to me that there is a risk peppered all over the system that needs to be addressed because we have to provide a safe health system for people so the harm doesn't come to them. Now, in the NHS, we know that 3 in 10 patients have got serious harm occurs to them as a result of interacting with the NHS or the NHS failing to help them. And I'm actually really concerned that that's going to become a reality in our country.
Yes, so true. And that's very sad. That would be very, very tragic if that happened. So, I mean, someone actually put in the Q&A tab. I know this is a very provocative question, but, how about a live debate between yourself, Anita, and Margaret Fore on the ABC to get the GP reputation back on track? Would you be?
Oh, I'd be delighted.
Oh,
Do you know what? I have, I'm not, look, we've all got to be sensible, diplomatic, intelligent and sophisticated when we do our advocacy. But I mean, Margaret Foe's PhD was critiqued in great detail at the time, including by a team at the college that looked into it. And I can say with confidence that the conclusions that were drawn from that document did not represent the data, and it certainly didn't represent any power within that data to extrapolate to the extent that she did. So, I mean, there would be points that I'd be very happy to make.
Yeah. And on another note, you mentioned about how patients can be our biggest advocates and be a strong voice for us to make the government sit up and listen. Someone's asked, how do you propose that we engage patients and the general public to bring them onto our side and kind of give us traction?
So actually, there was a really interesting study that was done in the 2000s or 2010s, I can't remember now, that said that while in general, the public might say, look, GPs, I don't know about GPs, but
Yeah.
when you talk about their GP and their clinic, they're like,
Yeah.
but my GP is awesome
Yeah.
and my clinic is the
Yeah.
bomb, right?
Yeah.
And so there is an enormous opportunity in that to say to patients, not can you go to bat for GPs you've never met before in a state that you don't visit very often, but patients can be recruited to defend their GP and their clinic because they know from lived experience what the value is and what that environment provides to them in terms of health and well-being. So there is an opportunity there. Look, we need to be unified as a community. Probably
Yeah.
the single biggest saboteur of all of our efforts so far in advocacy has been our own internal division. We are a
Yeah.
broad church with very broad politics, very
Yeah.
disparate politics.
Yeah.
But I would put it to everyone that actually in the next 2 years, we really need to decide, details aside,
Yeah.
we need to all come together because we are going to be so defunded and devalued that our existence will change immutably.
Yeah.
And once we're on the other side of that, we will be repenting at leisure. So my intent is to ask our community to come together, even if we don't see eye to eye on every political point. Because we must do that because the government, I think, sees it as a win when we behave in a divisive manner.
We are going to be a toothless tiger if we don't band together. And look at every other group or college or guild. How do you think they have so much power?
Yeah.
We need to really, like you said, band together and drive a big force. Let's move to the topic of urgent care clinics. A lot of funding. It was like the super clinics, the white elephants that the government had done many years ago. Now we have the urgent care clinics. We know that the average cost of a visit to the urgent care clinic is multiples of a GP visit, right? If I do get a discharge summary or a letter, from them, if I don't always get it, it'll always tell me to then do follow-ups and do something else. They haven't actually closed the loop. So how are we saving money and how is it serving our patients better?
Look, the fact is that I don't think that urgent care clinics at this stage, when you look at them in an aggregated manner, have done much at all to relieve the burden on emergency departments. And many people may have read the article in The Age where Sarah Whitelaw from the AMA was interviewed about that, and also GPs, fantastic GPs from our community were interviewed. Reflecting that. Now, I do recognise and I respect and I reflect that there are some urgent care clinics around our country that GPs are working in that deliver enormous value and to their communities, and they are working very, very hard, and there are genuinely a need for them to be there, particularly in areas where there aren't hospitals nearby, and I've witnessed that firsthand. But I do know that in the main, urgent care clinics, particularly the tranche that have been rolled out by the federal government recently, is a politically motivated, and it does concern me deeply because I know that it's not having the impact on emergency departments that it's purported to. The reason why I'm so concerned is that we are being demonstrated that the government is willing to disrupt the whole of the general practice industry by going into direct competition with mum and dad, everyday GP owners, and saying, well, we have got unlimited funds. We've got an entire health system budget that we can use when we go into competition with you. We're willing to spend between $250 and $300 a service so that people can have free care there. whereas the GP down the road is using the paltry, $60 maximum to try and do the same thing, and has to charge privately if they're going to use disposables and dressings in their treatment room. So
Yeah.
the fact that the government is willing to put that much pressure and interfere in the industry in that way bothers me deeply, because it means that they're quite happy to apply so much pressure on the clinics as to force them to close, or to shame them into bulk billing, which we know will force many of them to close. So I do know that Mark Butler has been asking for frank and fearless feedback about urgent care clinics, and I would want to take the opportunity to have that conversation, but particularly to say, why is the government wanting to apply so much pressure on general practice, which is holding up the health
Yeah.
system and potentially send all of these businesses into insolvency? What would motivate
Yes.
a
What are you going to
government
achieve?
to
Exactly.
destroy those businesses and those health services and leave patches and deserts
Yeah.
all over the country, like we've seen in rural areas in WA, for example, and elsewhere? Why would you want to do that? If you are the responsible custodian of our health system, why do you feel it's reasonable to allow these businesses to close?
So, what do you propose for the disadvantaged, segments? For example, you've touched upon the rural and regional Australians who do miss out because there's not enough services there, GPs and specialist services, and maybe let's talk about the First Nations people as well who don't have access, same access. It's not an equitable sort of access to healthcare services. So, what do you have in mind to help that segment?
So similar to the comments that I made about my belief that community health and RCHOs have a very important role to play for vulnerable populations, but I also believe that vulnerable populations should have access to a particular funding structure that essentially fills the gap for them, and so particularly in recognition that they may need more care, or that they may need care coordination, etc. I think that a person who comes from a socioeconomically vulnerable group should have access to funding system that boosts them, that recognises that they're not going to be able to pay the gap. Now, inside of a community health centre or an RCHO, that would be fantastic, because that can be a space where the fee-for-service has less of a role to play. But also, I think that we can recognise that people with particular comorbidities, mental health, living with whatever disadvantage, they should be able to trigger off additional payments that reflect that complexity, and that relieve them from having to pay a gap, but also recognise that the practice is going to have to spend substantially more time caring for them and then also coordinating the care. One of the things that I've said, Anita, also is that we've been told by the government that the multidisciplinary teams are the future of general practice. And we would be able to do so much if we had the right personnel in our general practices, like a social worker, for example, looking after people who are vulnerable and doing a lot of the social work that falls on the shoulders of GPs. But despite years of advocacy, we're yet to see the whip increase so that we could actually employ people that can do that work. So my question is, if we really are serious about establishing multidisciplinary teams in Australia, why are we being hampered by not getting the whips and PIPs, actually, that rewards general practice for saying, yeah, I'm going to take this to heart, I'm going to set one up, and I'm going to set one up in a way that reflects the population that I'm treating?
So there was a question about, in the previous theme when we were talking about registrar training and placements and, capacity. I think someone asked a question. I couldn't quite understand the exact question, but it was about any chance of changing the role about uptake of registrars in the new practice and not limiting it to current existing ones. So I guess meaning opening the door to many more practices to take registrars in. I know the college has certain sort of restrictions, how many per supervisor and what qualifications the supervisor needs to have. Um, but is the college going to look at a different model of having more practices be able to invite registrars into the practice?
Yeah, this is an absolute priority and a focus, and this work is already underway. We recognise that we need more practices and more supervisors if we are to meet the needs of training for the future. Look, it's a vexed issue because sometimes we, in response to the fact that things do go wrong, unfortunately, and registrars have had experiences that are exploitative or unsafe, for example, we recognise that we need to have a standard for accreditation of training practices, and we need to have a universal standard in terms of quality of teaching and safety and appropriate supervision, because we have heeded the feedback and the response and the experience of registrars who have told us that in some environments things have gone wrong and things have happened. And so in respect of those experiences and the need to act, the college has said, look, we need a universal standard and we need everyone to rise to that standard.
Yeah.
Now, that can cause some controversy because where there is a standard for quality and safety and supervision, then there is effort that's required to meet that standard. But we do believe that safety and very positive and well supported experiences are very necessary. The well-being and the experience of registrars is a huge priority. But there will be change management that's required as we get people to understand what is the purpose of these standards and how do you get accredited. And I think the college can do more to really try and help people understand what's required. The requirement to be a fellow, to have fellowed in order to supervise, that will not change. And I have spoken to people who do believe that it is reasonable that if you are teaching the fellowship, you do need to have fellowed yourself. But I do recognise that in some instances that has caused frustration.
And I know there were 1 or 2 years where there was fewer applicants and more practices offering, to positions, so it became a bit of a scramble, and they could only allocate one per practice. It was painful. So let's move to the next theme and talk about the complexity. And so we kind of already touched upon a lot of those things about the time that it takes for us to manage our patients, the mental health, problems, the multimorbidity, the psychosocial, needs. And, there's more than just the medical side of the consultation that we GPs provide. So I know I guess goes back to, and you've already answered about how you are really very strongly lobbying for better remuneration for these kinds of patients, so that you deliver good care, which we do anyway. But I think we need to be recognized for it more and more. You've talked about, like, you've made it very clear that discharge summary is a terrible term, but even any communication with the hospital definitely needs to be improved. So they talked about it, like in this theme, like a lot of respondents have talked about fragmented teams, and that GP is not being recognized as the leader of the multidisciplinary team. They just get sidelined, right? So how can we ensure that GP is front and center of any team that is going to look after and be part of that multidisciplinary care? Because we know that is the best model of care. We can't do it alone. I even teach my registrars, you got to work smart, enlist the help of other people in the team to give their expertise in what they do best. And you are the central coordinator, conductor, and the person overseeing and looking out of the patient as a whole.
So there is no doubt in my mind that the only person who can appropriately take on the responsibility of clinical governance in a multidisciplinary team is an expert generalist. Nothing will convince me that a person with less training or who has a single interest, for example, is able to do it. And if you think that you can do it, it's because you don't understand it. So the only way that you can be in charge of the clinical governance and understand undifferentiated illness, uncertainty, huge complexity, complex multimorbidity, and in the intersection of that with things like mental health and the social determinants of health, is to be a highly trained expert generalist. And so I defend the term GP-led multidisciplinary teams, because without the GP being in the lead, I think that there is an unacceptable risk in terms of the clinical
Yes.
governance.
Yeah.
But I also recognise that I don't want GPs doing things like this occurs in the NHS, where they almost not seeing patients anymore because they're really just
Yeah.
sitting in an office signing everybody else's script
Yeah.
and answering everybody else's questions, and not actually using their expert generalism, because they've just become really a rubber stamp for every other clinician in the practice. So we have to be the most important thing with this multidisciplinary team opportunity is that GPs and expert generalists have to co-design and
Yeah.
tell government this is the best way to do this, because we are the experts in this. We will tell you, we will help you, we will collaborate, but you must let us design it, because we are the ones who know what is required.
Yes.
Because if we don't do it that way, and if we have the MDTs designed by people in Canberra without our input, then I am concerned that we will have situations like we see in the NHS where, it's pandemonium basically. And so we have to be the ones co-designing and using our expertise, not just to lead the MDTs, but to create them. And
Yes.
so I feel strongly about that. Yeah.
On that point, you know how we have the allied health services, the government keeps saying, oh, you can give your patients these allied health services, 5 total for a whole year for a multimorbid patient with 5 different chronic diseases. How does that work?
Well, I think I think the intent was good initially, and I applaud that at the time when this came in, there was a recognition that there was care coordination, care planning required for chronic disease, and that you needed to involve other people in chronic disease management. So I applaud that, and that was a step in the right direction. I think what was underestimated and underappreciated is that true chronic disease requires more allied health input than you can get out of 5 visits, and that true chronic complex multimorbidity, by definition, will require more than one practitioner. And so when you start dividing 5 by multiple practitioners, you're not left with anything
No.
particularly meaningful.
Yeah.
But I think so so beyond pleasing the patient who feels that they're getting something, that's one goal, right? And that's a political goal.
Yes.
But a medical goal is to actually improve outcomes and keep patients out of hospitals. Now, it is much cheaper to have more visits with a physio or a dietitian or a psychologist or an Aboriginal healthcare worker, or whatever the case may be.
Yeah.
They're going into hospital to get the same care, or going into hospital because you came significantly sicker. So one of the challenges, I think, in conversations about health funding is convincing governments that you need to spend in order to save. And so you need to be seeing many years ahead of your current budget cycle.
Yeah.
And you need to convince people that you need to invest, even if there is a chance you may not be the incumbent when some of those rewards are reaped.
Yeah. And I think the way the government is going about it now and has done so for the last decade or so, to me, is really reeking of penny wise and pound foolish, the way they're cutting back payments to GPs, which delivers multiple, fold the return to the community and saves health dollars, but they're not looking at it that way. Before we move to the last theme, I think there was a question, I think, about like, we talking about patient advocacy, which is great, but why is it that there's a question from in the Q&A tab about patients have this perception that we doctors, of course, are greedy, but we're rich. You hear flippant comments like, "Oh, I better pay the bill so that you can buy your next car," and I feel like saying, "Well, that's the dermatologist or maybe your plastic surgeon, not us poor GPs. We are the poor church mouse. We are not we're the most overworked, underpaid, medical discipline." But why is this perception in the community about all doctors are rich?
So I think that when people conjure up in their mind's eye, the image of a doctor, they just automatically go to cardiology and orthopedic surgery.
Very
And I don't think that they understand the differences in the earning capacity. But there are a couple of things that are really important in this conversation. So the first thing is, if you think about what we do,
Mm.
the training, the responsibility we shoulder, the decisions we make, the regulatory and compliance environment that we exist in, the sheer amount of money we spend on insurance and every other regulatory body and every other fee, and the fact that we spend dozens of hours every year educating ourselves. I would put it to the public that we actually have every right to earn a very good wage for taking on that service for the Australian community. And I'd also say, I don't know if many people at the end of the plumb are coming to their house saying, "Oh, well, I better pay the bill so you can get another Mercedes." Whereas in actual fact, a lot of tradies earn orders of magnitude
And
more
us.
than any GP.
Yeah.
So the reason they say that is because the government has sent a
Yes.
message which used to be subliminal and now it's just overt, that
Yes.
no person should have to pay to go to the family doctor and that they should do that for free. And if they don't do that for free, they're being greedy and inappropriate.
Does
And
RACGP have a strategy to counter that in the public domain?
I think a lot of people have said you really can't talk money when you talk in public about medicine because we get shot down so easily
Mm.
by the greedy doctor narrative. I have
Mm.
bucked that trend. I've written articles and I've had conversations in the media where I've said, actually, hang on a minute. First
Mm.
of all, your assumptions are inherently incorrect. And I'm not a plastic surgeon and I'm not an orthopedic surgeon. So let me put that on the table. But I also want you to appreciate what the job is that I actually do and what responsibility I take on your behalf and how much education, training, how much it costs me to run my business, how much it costs me to insure myself. So the other thing is if you want to pay peanuts, you will not get highly talented people going into the specialty because they'll say, I'll take my talent and my efforts elsewhere. So look, there is a narrative in the community that is very anti-authority, anti-doctor at the moment, anti-science. And I do think that we have to say, hang on a minute, when you say that to me, you make me feel like you think that my services here aren't of any value. And I believe that what I do here is of significant value and I'm a highly trained professional. I'm not sure that people say to their lawyer or their accountant,
Accountants or anyone. Yeah. And I
yeah,
think you're right. We GPs
dream
need
of
to
it.
stand up for ourselves and tell our patients in a very polite manner. Sometimes I remind my patients sometimes if there's a talk, I mean, we don't like talking about money, feel very uncomfortable. But when they raise it, I always tell them, do you know how much unpaid work we do? And if I break down my hourly rate, I'm earning less than an administrative assistant. And they look at me shocked. Because
Yeah.
there's a lot of behind the scenes time I put in and do stuff for you. And, I mean, most of our patients are very appreciative. They realize some of them will turn around and say, "You saved my life," or, "I really appreciate what you do. You make such a difference." But I think we need to really be proud of what we do, and we need to reflect that. And I don't think it's arrogance, but we need to just say it like in a nice way to patients, make them see how difficult it is to actually do this balancing act. I think that's where there'll be more and more awareness. Let's move to the last theme, which is voice, identity, and trust, which is, I guess, the most important. So now, Anita, what do you think the RSAGP should be prioritizing clearly in the next 12 months, and what do you intend to do if you were to take that role on as the president? So what will you prioritize first and foremost? I know we talked about so many different areas of distress, so
Mm.
many things that need to be changed. But like you said, Rome wasn't built overnight, and it's not going to take one visit to Canberra. It's going to take a lot of conversations. It's going to take a lot of other people, a lot of voices. But what do you think you'll prioritize over the next 12 months?
So I have interviewed and spoken to dozens and dozens and dozens of GPs. In fact, over the 6 years, it's hundreds being chair. And the thing that they are saying most is distressing them is the lack of respect and recognition for our profession. So that is the theme that is my highest priority. Now, you don't just go to Canberra and say, "Can I have respect and recognition, please?"
Oh,
That is the strategy, and that is the priority. But what we're talking about is I want that demonstrated in monetary terms. I want appropriate remuneration. I think we do need an independent pricing authority, because I think that pricing in general practice has become a political football. There is uncertainty, there is political whimsy. RACGP has been asking for the pricing authority for some years, so that is an RACGP policy, but we must go after that. Now, we can piggyback off the Grattan Institute is also saying you need to have an independent pricing authority for pharmacy to rein them in, because of the spending there is just unchecked. And so it's actually a great time to say, well, independent think tanks are saying that we need this, and this is what we need, because there is trust has been lost between general practice and the government. We don't trust that they will allow us to use item numbers and to generate an income that is fair. They don't index. We saw that immediately, and I knew that would happen. Of course, it was always going to happen. They were never going to index to CPI, because they never have.
in fact, they put a freeze on us for a while.
They have frozen us. They were never going to index to CPI. And so when you've signed a deal with the government that says, all right, I'll trust you, I'll bulk bill, I'll use this incentive, but you have to recognise that the cost of business is enormous. And the first thing they do, fewer than 12 months later, is say, you're getting half of CPI. The trust is eroded. So an independent pricing authority, fair remuneration for and particularly recognising the complex comorbidity. But also, I think we need a public campaign that says that this society needs to understand what expert generalists are, and why we are propping up this entire health system, and why it's going to be an absolute catastrophe if any more of it is lost. And so that's an absolute priority. The internal priority, I think that we do need to continue the work in terms of some of our internal bureaucracy and processes, because I do know that members continue to feel very frustrated. The college has come a really long way. We do have an outstanding CEO in Georgina van der Water, and I trust her, and I know that she has a vision, and I know that she's going to deliver on it. But I do recognise from a member point of view that there are still frustrations, that we're looking to improve their experience and improve the efficiencies and some of the processes that we have inside.
Now, I want to just bring up two very, very interesting and very, relevant comments here in the quick Q&A. So there's one that says that unfortunately, Dr. Anita Muñoz, even in medical homes model, MDT as it's called here, and in the USA or Canada, government-funded projects, they are mostly nurse-led. The scope of practice / Medicare reform workshops that he attended 2 years ago, this attendee is telling us, by Dr. absolutely were blatantly against GP-led teams.
Yep.
How are you going to initiate a paradigm shift here?
Yep. And I was, and others have been, absolutely scathing of that project and that review. And I went to those workshops myself, and I made that very clear. And in submissions afterwards, when I've been in Canberra, I've said that it is just that it was a predetermined outcome, and how you can have a conversation about primary care and leave GPs out is absolutely beyond my capacity to compute. But of course, I do understand it's politically motivated, and it's because people believe that the NHS is the right model for Australia. And so I understand why it happened and where it came from. Now, having said that, a lot of what that report actually suggested has not come to pass, because I think a lot of people said that this was just it's so inappropriately executed as now to be of limited value. And so I agree with you. I was absolutely furious about the way that was conducted, and I was very comfortable having my my views made clear, not just in our formal submissions and attending, but when we've been in Canberra. So I think we need to make it very clear that the MDTs must be GP led. The evidence is that when you have no GP involved, it costs you more. People over order, over prescribe. There's double servicing, because you get a service here, it doesn't work out, then you actually end up at the GP, or then you end up in emergency, and actually costs burgeoned.
Yeah.
So we need to make that very clear that it's actually a very costly road to go down.
Yeah. I mean, you think the government would have learned from the big juggernaut of the NDIS that they created and, was an open slather for people who wanted to rot the system. There's another very interesting comment that do you agree that GP should take on a greater role in the primary healthcare networks in order to raise our profile, have greater input into health priorities and the funding that goes into them? Personally, I feel the primary healthcare networks sometimes are top heavy. Huge budget goes into administrative expenditure, computers, swanky offices, and I'm personally not impressed. What do you feel?
Look, I know that there are some PHNs around the country that are very highly functioning and do work very well. And so I'm a bit reluctant to refer to all of them as
No,
sort
you
of
can't put them with the same brush.
homogenous. But there have been multiple reports that have been written about PHNs that have pointed out that they're not delivering value for money, and they're very expensive, and they're basically just giant commissioning agents that, in many ways, are not commissioning into general practice as much as we really need, and in fact, they go out and they commission to anything but general practice in some
Yes.
instances. Now,
Yes.
having said that, I got into college life initially because I was disgruntled as a member because of certain things that were occurring at the time, and this is sort of around 2016 or 2017. And I really quickly formed the view that if I am disgruntled about something, probably the best way to get in and affect change is by being involved.
Yes.
Now, so the answer is I think it is very important that wherever there is a conversation about general practice and primary care and community care, GPs must be in the room, holding everyone to account and being truth tellers. But I do also recognise that there are some PHNs where it can be very stifling and difficult for GPs to get any purchase on the conversation. But in general, I do believe that we are better off being everywhere and our voice being everywhere than hiding in the shadows.
Yes, exactly. And you cannot make decisions for primary care without primary care being involved, frankly speaking.
Yeah.
Anything you do.